So for this session, I now invite Dr. Venkatakrishnan, Dr. Tilagavati Madam, and Dr. Samuel Dinesh Sir to chair the session.
So good morning, everyone. We'll go to the second session for today's, where we have a scientific agenda about varied aspects in diabetes, starting from every time we always discuss about prevention of diabetes. Still, we are confused about whether it's a reality. In diabetes, always we feel it is insulin is the only medication. So what are the oral drugs that will be safe, which can be administered in pregnancy? The third topic is about how diabetes manifests differently in females than the men population. So we have three speakers. As usual, we know Dr. Bhavnani, who doesn't need any specific introduction, Dr. Sunil Gupta and Dr. Aarti Kannan. We will move on to the first session from Dr. N. Bhavnani Madam. We welcome you, Madam. Prevention of diabetes, an untold reality.
Thank you, sir. Pranams to our Bhishma Pita of pregnancy diabetes, Professor Dr. Seshia. And I want to say our chairpersons that it has become a reality, sir. It's no more untold reality. So, if you take female gender, that is the key for main diabetes prevention. And how, if you take diagnosing a GDM, identifies a future woman at the risk of diabetes and also the other metabolic problems. And in the child, the maternal hyperglycemia is associated with the development of metabolic problems in the future and then also. And Jocelyn long back said, the blood sugar in the mother has to be controlled to the extent that the fetus no longer feels that the mother is a diabetic. If you do this, this becomes the first step in the prevention of diabetes. So this is an opportunity for primary prevention of cardiometabolic disorders. If you take the developmental origin, the ovum is well supplied with mitochondria, but the sperm contains a few, and even those few do not persist in the offspring. At fertilization, it is only the nucleus of the sperm that enters the ovum, and all the cytoplasm, mitochondria, and mitochondrial DNA are exclusively maternally inherited. This has been done long back in the 20th century by David Barker, that body's susceptibility to lifestyle diseases was programmed in utero, that is intrauterine. What is this intrauterine programming? This is nothing but a gestational programming whereby a stimuli, that is maternal fuels or stresses that occur at this critical period or sensitive period of fetal development permanently changes the structure, physiology, metabolism, and predisposes the individual to diseases in adult life. This is the fetal origin of adult diseases. So we thought we'll screen as many pregnant women as possible because proper screening itself is equal to good management. Keeping in this mind, instead of doing a high-risk-based screening, what we usually used to do, and doing at 24 to 28 weeks, all that's given, and instead of using the cumbersome GTT, our national guidelines came with an easy, economical single step with 75 grams of glucose that can be given in the fasting or non-fasting state for all pregnant women in the first trimester, and if it meets 2 hours, 140 or more, it is branded GDM. In spite of screening so many pregnant women, that is almost all pregnant women between 12 to 14 weeks, and bringing them under control, all the prenatal problems, that is the preterm, eclampsia, big baby, all we were able to bring it down. But not the later childhood obesity, early IGT, future diabetes, and other NCDs, they all continued to increase. Our father of GDM, that is our Professor Seshia, who thought that diabetes is going to rule the future long back in 70, and he started the first department of diabetology in the country in the government setup, and he thought that for further managing we need adequate people, and he also started the diploma in diabetology for the first time in the country in Madras Medical College. And even then, we were not able to control, and he found the place where this starts. So the root is in the pregnant woman. So he wanted to screen all pregnant women with a easy single-step procedure, came out with a Tamil Nadu model, that is a single-step procedure which is followed everywhere in India as well as in some other countries. But still, in spite of doing all this, we are not able to bring down the incidence of diabetes. So he has come out very recently with the concept of primordial prevention of diabetes. If you take in GDM-prone women, they are already insulin resistant. They have hyperinsulinemia, which is the driving and initial factor in the development of metabolic disorders by affecting the placental growth, angiogenesis, and lipid metabolism. The placental response is initially from the mother's side. Later, the fetal cytotrophoblast takes over this, and this causes all the problems by fetal handling of the maternal blood sugar. This insulin resistance with hyperinsulinemia in GDM causes increased atherogenic lipid profile, inflammatory markers in hypertension, endothelial dysfunction, leading to all the cardiovascular diseases later in life. So our mentor said, GDM is the mother of all non-communicable diseases because it's just a legacy effect later. What is the effect of this maternal, initially the hyperinsulinemia, and later the fetal hyperinsulinemia and diabetic pregnancy? As I said, those who have already hyperinsulinemia, insulin resistance, what happens? There is rise in blood sugar, and this hyperinsulinemia causes problems in the placental growth, angiogenesis, everything. As I said, the increased blood sugar in the mother passes via the GLUT4 and GLUT1 transporter into the fetus, and there it increases the insulin secretion, which take over the function of the mother and causes again the affects the placental growth, angiogenesis, and not only this, it causes increased fetal growth, macrosomia, and by stimulating the fetal beta cells further and further goes for exhaustion and development of type 2 diabetes later in life, and by causing cardiac hypertrophy, it causes the cardiovascular problem, and fetal fat deposition causes obesity much earlier, and the impaired hypothalamic development causes effects on feeding behavior, and the fetus takes more and more. That is the child in future. Thus, the maternal hyperglycemia and fetal hypoinsulinemia are the kingpins of pregnancy metabolism. If you see those who had fetal hyperinsulinemia, that is a child who has more of insulin because of the mother's blood sugar, had more of obesity in the childhood, and also they developed very early the impaired glucose tolerance almost at 12 years itself. If you take the normal fetal insulin level, those fetuses which have a normal fetal insulin, they only 1/10 of them developed IGT later because of the environmental factors like overeating, sedentariness, all that. This has been long said by Metzer in 1990 itself. So what we do, usually we think if we detect diabetes, yes, we can control the disease itself. No, organizing camp or detection of diabetes does not mean we have prevented the disease and brought down the incidence. What we need is primordial prevention of diabetes, that is, the disease should not develop, says our mentor. Detection, diagnosis of GDM is impossible. What we are concerned is prediction of GDM, so that we can prevent the development of GDM as such and its consequences, which is very important. So when to test to predict this GDM? NIH analysis suggested that early screening could allow the lifestyle changes before the condition develops. You should start well ahead. You should not allow the condition to develop, then treat it. It's of no use. So single blood test may identify the gestational diabetes risk in the first trimester. It suggested that it has to be done at 10th week. Why this 10th week? If you take the pattern of glycemia in pregnancy, that is, Hernandez, after studying for almost 40 years in so much of pregnant women, he has come out with a normalcy in pregnancy that fasting always less than 80 and 2 hours should be always less than 110. It should not touch 110. He says it's between 99 plus or minus 10. That means it should be between 89 and 109. It should not touch 110. Why this 110? If you take the embryology of the beetle beta cells, the human beta cells develops by 7 to 8 weeks and starts functioning by 10 to 11 weeks. Then each islet cell functions as an endocrine organ controlling the mother's blood sugar. This is the fetal handling of blood sugar. I'll say by an example. For example, if you are seeing a pregnant lady at 10th week, her blood sugar at 2 pp is 126. And she's again later reporting at 12th week, see her blood sugar has come down from 126 to 112. The pp has come down without any intervention. How this has happened? At 11th week, there is starting of fetal insulin secretion. This has brought down the maternal glucose. The maternal blood glucose does not go up because of the fetal controlling the maternal blood sugar by secreting more insulin. Whenever the maternal blood sugar crosses this 110, immediate action has to be taken to bring down this below 110. If not, she'll develop GDM and you'll have all the consequences later. See here you can see that maternal blood sugar looks below normal at the cost of hyperinsulinemia in the fetus. This fetal and hyperinsulinemia is likely to present before GDM diagnosis. That is what we do routinely at 24 to 28 weeks of gestation. The fetal glucose T lambda could mask the maternal hyperglycemia and may increase the risk of false negative GDM results. Adult renal threshold is 180, likewise the fetal renal threshold is 110. During gestation, the lower level of blood sugar prevails in the mother compared to the fetus. Since the fetal renal threshold is 110, whenever the blood sugar is more than 110, the fetal senses it as hyperglycemia and secretes insulin to control that. This fetal secretion starts at almost 11th week, but the problem is once the fetal insulin starts secreting, it will not stop. It continues throughout gestation and postnatally throughout life. Initially, this fetal insulin secretion helps to reduce the mother's blood sugar. Later, this continues and steals glucose from the mother as long as it is inside the mother. After delivery, the mother's glucose supply is cut off, so it goes for recurrent hypos. In future, because of hyperinsulinemia, it has more hunger and eats more and develops all the non-communicable diseases. This hyperinsulinemia is the problem creator of all non-communicable diseases. Based on the fetal renal threshold 110, NIH has come out with a HbA1c cutoff of 5.3, which corresponds to the 110 blood sugar. It's very difficult to do HbA1c in all pregnant, so just a blood sugar corresponding to that if you see 110, you have to take actions. It has to be brought down below this before the fetal insulin starts. Another problem, the maternal insulin resistance, that is overweight to hyperinsulinemia, again it is tied with issues in the sons. A study published in AOG suggests that women who are overweight or obese during pregnancy are more likely to have infertile signs because it affects the development of male offspring's reproductive system. So prediction of GDM is 110 at 10th week. So to bring down this less than 110, preventive actions has to start at 8th week. If the PP, postprandial blood sugar at 8th week is between 110 and 119, start with medical nutrition therapy and metformin and continue till delivery. The priming of the fetal beta cells around 11th week may account for the persistence of fetal hyperinsulinemia throughout pregnancy and throughout life. And again, don't worry about metformin. It is safe for use throughout pregnancy. It has been approved as the first oral anti-diabetic medication that can be used from conception to birth. And since the preeclampsia and hypertension all are again features of insulin resistance, this controls the hypertension and preeclampsia also. Thus, prevention of GDM is possible if you bring down the blood sugar less than 110 at 10th week. When the beta cells start secreting insulin, we should stop this insulin secretion. This has been done by Dr. Picky Saxonsa at Delhi, that she has compared those with more than 110 and less than 110 and found all the problems, that is the neonatal problems, pregnancy outcomes, indication for LSCS, neonatal morbidity, maternal morbidity, all has been much, much less in blood sugars less than 110. So we need to remember certain glycemic levels for diagnosing different categories of glucose intolerance. That is, if you have 2-hour plasma glucose more than or equivalent to 200, it is diabetes in pregnancy as well as outside pregnancy. If it is more than 140 and less than 1199, it is GDM in pregnancy and impaired glucose tolerance outside pregnancy. And again, remember this, in pregnancy for glucose, if the value crosses 120, you have to be very cautious. Here itself, your problem starts, that is gestational glucose intolerance, and you may have all the problems. And the other new term, the EGGI, that is 2-hour postprandial more than 110 at 8th week, is early gestational glucose intolerance. So remember, just one blood test at appropriate time, that is 8th week, prevents transgenerational transmission of diabetes, and GDM is the window of opportunity for prevention of not only diabetes but all the cardiometabolic disorders. So as our professor, mentor, godfather says, diabetes for diabetes-free generation, focus on the fetus for the future. Thank you.
Thank you, madam. It's a wonderful presentation, extensive coverage. Protect the fetus. So prevention of diabetes is a reality. So we'll move on to the next speaker.
It's my pleasure to welcome our esteemed speaker, Dr. Sunil Gupta. He is a leading diabetologist and CEO and MD, Sunil's Diabetic Research Center, Nagpur. He is a recipient of numerous national and international awards, including Young Person of the World. He is a true pioneer in diabetic research education. He has also held a leadership role in National President of DIPSI and Treasurer of RSSDA. He is going to talk about non-insulin therapy in diabetes in pregnancy.
Good morning, everyone, and thank you very much for your kind introduction, ma'am. At the outset, let me take this opportunity to take blessings from my mentor, Dr. V. Seshaya, sir. Such a first to you. And this particular session has been dedicated to, all of my session on pregnancy diabetes is dedicated to Dr. Seshaya, sir, and today also I say that. So my today's talk is little non-traditional. Usually I talk on insulin therapy in pregnancy diabetes, but today I'm going to talk on more into oral drugs and non-insulin therapy in diabetes in pregnancy. So congratulations for a wonderful session, and thank you very much from the team of Hello Diabetes. I don't have conflict of interest. I'll have some 1 or 2 slides on introduction. Most of the part has been already covered by Dr. Bhavatarani, so I'll not speak on that. Glycemic targets have been discussed, so I'll directly go to MNT, maybe 1 or 2 slides, and then go for oral drugs, which is more important for we as a clinician, and then the carry-home message. I feel these are some terminologies which have been used very recently, that you have conventional GDM, which is usually appearing in the 24 weeks onwards. Then we have come out with the pre-gestational diabetes was defined by different people in different names. They say over diabetes, that you were detected to have hyperglycemia for the first time during pregnancy, but the cutoffs are matching as that of the known diabetes or unknown diabetes earlier. So cutoffs of WHO cutoffs or IDF cutoffs of 200 random or post-glucose 200, HbA1c more than 6.5, fasting more than 126. That's called as overt diabetes, or it was earlier we used to call it as pre-gestational diabetes. And FIGO has defined it as a category in DIP, that you are pre-existing type 1, type 2 diabetes becoming pregnant, that is DIP. And most of these women who are known type 1 diabetes, known type 2 diabetes, will ultimately need insulin therapy. In most of the cases, very rarely they will do well only good on medical nutrition therapy alone. Early GDM was again a newer terminology which is being used, that if you have GDM cutoff less than 200, between 140 to 200, but being diagnosed little early in the maybe first trimester. And I still remember the data of Professor Seshaya sir and the group from Chennai itself. that there are around 18 to 20% of these pregnancy have been diagnosed the first trimester before 12 weeks. So this is all opens our mind with that we have different kind of patients. So when you talk about non-pharmacological treatment, that includes a medical nutrition therapy and some oral drugs. Most probably 70% of GDM women will do well with medical nutrition therapy alone. 20% of them, many of them may do well with metformin alone, if not contraindicated, and rest of them may need insulin. But one should be remembering one very important clinical point here, that if the patient is put on metformin alone, almost 30% of these patients, or sometimes 50% of these patients, may not achieve the targets of 90 and 120, which has been proposed in the pregnancy as the pregnancy advances. So though it's a good drug, very well welcome drug, now the safety data is available, but still it's not a very strong glucose lowering therapy when it comes to GDM, and many of the women might need additional insulin therapy to metformin. Mild GDM is GGI, which Bhavatarani just has shown, 120 to 140. We have to be little alert on these lines, and they should be put on diet therapy. And our own data, I'm not going to show here have shown that almost 17 to 18% of these women who are mild GDM, diagnosed just as mild GDM with one, people call it as IGT in pregnancy, we used to call it as isolated abnormality of blood glucose, IABG. Now DIPSI says GGI, gestational glucose intolerance. So even these women, of 80% may do well with medical nutrition therapy, but rest of the 20% may need even insulin therapy in the follow-up. Especially if they have bad obstetric history, you have to be ultra careful of this reading between 120 to 140 after glucose challenge. Glycemic targets already discussed, so 90, 120, and these are the, some says 95, DIPSI says 90, 120. What is the role of HbA1c? Your target of HbA1c in type 1 as well as type 2 preconception ideally should be 6. Acceptable is 6.5. In view of high risk of hypoglycemia, you can accept up to 7, but not beyond 7 to prevent congenital malformation. TIR, time in range, is a newer thing, and this is, we say that for type 1, 70% it should be achieved. For type 2, it should be type 2 pre-GDM and GDM, we should achieve time in range of up to 90%. And the cutoff of time in range is between 63 to 140, and not like 180 we have in non-pregnant state. So time in range between 63 to 140 in type 2 diabetes, pre-gestational diabetes or preconception phase, we should try to achieve up to 90%. So there are several treatments. Insulin is the drug of choice. The first drug of choice globally is insulin, but you have a second line of therapy is metformin, glibenclamide, and even acarbose had been added. So, but at the base, diet, lifestyle modification, blood glucose monitoring will remain as a part of treatment for every one of them. So we have the Government of India guidelines 2014 and 2018, and whenever we talk about medical nutrition therapy, I usually don't talk on, usually means 90% of time I don't talk on medical nutrition therapy because of my wife, because this lecture is being taken care by her. So I have borrowed some slide, 2 or 3 slides from there. So this is the Government of India guideline that 2 weeks after diagnosis of GDM, just wait for medical nutrition therapy. Try to achieve your fasting postprandial blood glucose targets. If you don't, then you go for pharmacotherapy. Metformin, as well as metformin by Government of India says after 20 weeks. DIPSI's recent guidelines published in 2023, we say now after 12 weeks we can certainly start metformin, and primordial prevention has already been covered, so that I'm not going to talk on that. There are different, as the first trimester, usually don't need to change the total calorie intake, the quantum, but the second and the third trimester, you may need to add, as well as in lactation, additional calories, and you can have add protein. This again, dietitian will come into picture. Try to take low GI food and low glycemic index and low glycemic load food. Even there are a lot of strategies now. You just, you can have splitting of the meals. Like South India, I have heard that we have very heavy breakfast here versus the center in North India, it is in the center India. So you can split your breakfast, take half of the breakfast first. After 2 hours, you can take the another part of the breakfast. Possibly the postprandial spikes will be certainly cut down, and you will be able to achieve these targets. So splitting of the breakfast, changing the order of the food. Take fiber first rather than carbohydrate. So if you take fiber first, and then the fiber and the protein, and then carb at the end, your postprandial spikes can also be taken care. Now, obesity is not a thing which is to be treated during pregnancy officially, but if suppose you have someone with you very obese, the neonatal outcome doesn't differ even if you reduce the calories by around 30% in these individuals. Exercise as per the protocol or as per the recommendation of the obstetric gynaecist. There is some DALI study which has again shown that if you have healthy eating habits along with physical activity, then certainly it might work. We have exercise has certainly improved the blood glucose control, insulin use, and weight gain and blood glucose. What are the role of oral drugs? So oral drug, whenever you use, it should not be crossing. Chairperson, I'll just take 2 or 3 minutes because yeah, please. The oral drugs which do not cross the placenta are the safest. Or even insulin never cross the placenta. Insulin doesn't cross the placenta, but all oral drugs will cross the placenta, including metformin, including sulfonylureas. So even if they cross the placenta, they should not cause hyperinsulinemia, they should not have teratogenic effect, and they should not cause hyperinsulinemia. So metformin, glibenclamide, acarbose, these have been tried. Metformin, I'll just go because metformin earlier analysis has shown that there is a IUGR seen in this patient, few of the patient, low birth weight at the time of delivery in the meta-analysis, and then there was a speedy catch-up growth in the first year or first 2 years of this baby, and that was an alarm that these baby are born small but are growing fast in the first 2 years of the age, and that's why it could be a risk for metabolic cardiometabolic risk in the adult life. But then we have a lot of other papers. There's a MITI trial in type 2 diabetes, and they have done the known type 2 diabetes. Metformin started before conception and continued till delivery. And what they say, and they have shown that the outcome is almost similar, except there is small for gestational age babies where more. And then now they have MITI KID trial. MITI KID trial is offspring of these mothers who were type 2 diabetes, 24 months, 2 years of follow-up of these kids, and they have found no concern of these babies who were born with metformin versus insulin group. And this is various trials which include MIG trial, MIG tofu trial, again have shown. This is a very recent trial of 2023 or 24, just published, long-term impact of these offspring of diabetic mother, 5 to 11 years, metformin use in these mothers, and this meta-analysis again has come out with, it did not show any adverse event, and that's why now we are getting consolidated our knowledge about metformin, its acceptability. What Professor Shea used to say long back, metformin we are using it, don't worry about it, so it's still there. Then you have MOMPOD trial, which is a metformin plus insulin in pre-existing diabetes. Wonderful trial around 500 to 800 patients, use of metformin plus insulin to treat pre-existing type 2 diabetes, as well as those GDM who were diagnosed in the early pregnancy. There is no issue as far as metformin group is concerned. And this is the next one, which is MOMOD trial. And then you have that was trial from US group, 17 different states, and this is a trial for European group, again have not shown any concern. So you have MIG trial on 750 pregnancies, you have MITI trial around 500 pregnancies, and now you have MOMPOD trial around 800 pregnancies. All of them have shown classically that not much issue of metformin use in pregnancy. Still, it is a tip of the iceberg. We have some registry which is going to come from Europe, and European organization has approved officially metformin for pregnancy. Sulfonylurea, we are not approved, so I'm not going to go into it. So India, we are not using it. There's a comparison for glibenclamide, metformin, insulin review, and they have shown that not much of the issues, and glibenclamide is a third still, and metformin and insulin can be used. Absolute indication, we have patients with very high blood glucose, ketonemia, renal impairment, IUGR, placental insufficiency should directly go for insulin. Lactation, you can use glipizide, glibenclamide, have been shown to be good, metformin, but insulin remains the drug of choice in lactation. And preconception counseling care is very, very important. We have 101 crores of diabetics. We have 10 crores of 10.1 crores of diabetics, 13.6 crores of pre-diabetics above 18 years of age. And if I just calculate the adult population of our country, around 90 crores, that means every fourth person after 18 years of age have either pre-diabetes or diabetes. And that is why these women are not going to be spared. So every fourth woman in preconception phase itself should be counseled and educated for it. And unfortunately, 90% of the pregnancies are accidental pregnancy. It has happened by mistake. And that mistake creates a migraine to a person like me. And then National GDM Day, which is a birthday of Professor Sheshaya. And then that's why DIPSI is doing their awareness program where all of you are the part of it. And rather, Tamil Nadu is the base of it, which started across the country. We started Prega Talk for Public Awareness program on 30th of January 2022. We started a second cycle now, and this cycle again I started from Tamil Nadu as a second cycle, and now we have completed almost 43 episodes twice in a month, and different languages. Indian Constitution have 22 languages. We have completed all 22 languages in the first cycle. Second cycle, our list is all 12 languages already covered. Last was this Friday, was Malayalam, the last one, and now another 11 are still remaining, including Dogri, which is from Kashmir. So we need your blessings and support for our public awareness campaign across the country, that every woman across the India, whether it is urban, semi-urban or rural or ultra-rural Adivasi lady, should be able to know what the DIPSI GCT test is, and everyone should be screened, should not miss out a single case of hyperglycemia and pregnancy. If you really want to see a future generation, when 2047 we will be celebrating 100 years of independence, if we really follow the intrametabolic milieu to be addressed very aggressively from the first day of hyperglycemia and pregnancy, we will not see a single case of diabetes when we celebrate 100 years of independence in 2047. That is our vision of DIPSI and Professor Sheshaya. Let's go ahead with this. Thank you very much for patience listening. Hopefully this time I have not confused you too much what I used to confuse you every time. So thank you, and this is my last slide, which is my pet slide. Wish you all happy Dashera, happy Navratra, happy Deepavali, happy World Diabetes Day, and happy New Year in advance. Stay safe, stay healthy, keep smiling. Don't cut the cake for celebrating any occasion. Cut the fruit and give another strong message to the society. Thank you very much for your patience listening.
Thank you, sir. It was very informative regarding non-insulin therapy, metformin in pregnancy. So extensive talk. Still, metformin in pregnancy, insulin is the drug of choice in pregnancy.
Yes, sir.
Thank
Insulin
you.
is the
Sir, a
still-
question for you. Sir, a question for you. Tablet glycoside is one of the choice of GDM. How about your thing? You said metformin. Glycoside can be used in
No,
GDM.
glycoside, there is no safety data available. It's only glibenclamide we have. Glyburide, the name which is written is glibenclamide and not glycoside. So it's only, you have only metformin, glibenclamide. It's very small data of acarbose. I feel most of us are not using it. And glibenclamide has not been approved by the government of India yet. Neither DIPSI has endorsed it. So better we be with only metformin and insulin. Insulin, those patients already on insulin, type 2 diabetes requiring very high dose of insulin, you add metformin, you will have a better control of hyperglycemia in such patients. Yeah. Thank you very much.
I call upon the third speaker, Dr. Aarti Kannan. Topic is, how does diabetic affect women differently than men? A very different topic. Diabetes affecting women more than men. Kindly explain to us in detail and prove the case. Thank you.
Respected moderators, co-speakers, respected senior leaders of the profession, a very warm good morning to all. At the outset, I take this as a big opportunity to thank both the organizing and scientific committee, Professor Anand Moses sir, Dr. Shanmugam sir, for giving me this opportunity to speak on how diabetes affects women differently than men. Already we've heard two dynamic lectures from two stalwarts who have been working for so many decades about diabetes and women's health. So it is an honor for me actually to speak in this session itself. Thank you so much actually for this opportunity. So for the next 12 to 15 minutes, I'll be taking you all through the life course journey of a woman and the few points we need to keep in mind when we see a woman sitting in front of us who has come to treat her diabetes status. Does diabetes actually, it's a very important question. Does diabetes actually affect men and women differently? However, diabetes affects men and women equally, but women are more severely impacted by its consequences. We do not have any guidelines which tell us that we have to treat women separately or men separately. It is going to be the same drugs, same insulin what we're going to give. But we have differences in women at every level. whether from the anatomically, physiology, biochemistry, pathology, and the pharmacology level itself. So diabetes is different in a woman when compared to a man. But we're not going to talk about any gender equality here, or it's not a women movement or something here. It's only about metabolic health. So when we see through the gender lens of diabetes in women, the experience of diabetes itself is different in a woman. The life cycle of a woman is different when compared to a man. And diabetes has more severe adverse outcomes in women. The socio-economic cultural context and other social determinants do play a big role in the management of diabetes of a woman compared to her own husband who has diabetes. And gender-specific health research technologies. We know a lot of trials which enroll only a small number of women in them. So the results of the trial actually may not apply to a woman herself. And we also there's an eminent need to address the gender equities in healthcare. And we also need to review the therapeutics with the genderless. So we need to gender mainstream, and we need more benefits for it too. So going into a little of the basics, as we know, the gonadal hormones do play a very big role in the protection of a woman till the perimenopausal period. That is mainly the estrogen. What does it do? It actually helps to reduce the hepatic insulin insensitivity. So increases the insulin levels. So and this insulin estrogen both prevent the beta cell apoptosis. It also plays a very good role in prevention of signaling of the pro-inflammatory adipokines. So there will be a decrease in inflammation, decrease in insulin resistance. It plays a very good specific role in sex-specific distribution of adipose tissue. That is more of a gynecoid type in females, that is more of subcutaneous, and android type in males, which is a visceral type. The visceral type is the one which has a greater risk of glucose intolerance and insulin resistance. And also, as we go into the perimenopausal period, the ovarian follicles start depleting. So the estradiol levels keep coming down. Then the postmenopausal period, it totally stops. We need HRT that time. So going on to the IDF atlas, with the global prevalence of diabetes in men and women, this statistics, as you can see, it shows that actually the more larger number of men have diabetes when compared to women. But as you can see, the difference from 2021, 17 million is only the difference. In 2030, it is predicted to be about only 14 million. And 2045, only 11 million. So actually, more and more women are getting affected. And we are actually catching up very well to men. And the diabetes-related mortality, it is found to be more in women than in men. As you can see, after the age of 60, death rates are more in women when compared to men. So with this, we had another study published by Dr. Mohan Sir and his team on sex-based differences in clinical profile and complications among individuals with type 2 diabetes seen in a private tertiary care center in India. This study was done in 79,000 people with equal number of men and women. And what were the results? They were followed up for 2 years. What were the results? Females had higher BMI. They were more sedentary, less physical activity, more obesity, more hypothyroidism, higher rates of cancers, higher fasting, postprandial, cholesterol levels. And after the age of 44, the control of diabetes was worse in women. And also, they also achieved glycemic control very less when compared to men. So this was a very, very alarming study which had come out. So there is a lifelong impact and interaction between sex and gender on development and outcomes of type 2 diabetes. Whether it is the social conditions or the biological factors, they influence the development of germ cells. Actually, we have put the seed into the germ cells. Epigenetic changes take place. The seeds of diabetes, non-communicable disease, have been fed in. Once it has been done by the 10th week, we cannot change the genes of that baby. It's going to be in a very, very adverse environment only throughout its life course and the development of type 2 diabetes and complications. So at any stage a woman comes to you, start treating immediately. There is no time to wait. We have already lost the bus when she was born itself. So we need to look into her whole women's life cycle and the metabolic changes. We need to concentrate at every level, from the intrauterine environment, birth weight, puberty, her menstrual cycles, pregnancy, breastfeeding, postpartum care. These are all exclusively for women. We are not going to share it with men. Perimenopausal and postmenopausal. All these levels, we need to act at each level with the changes at each level. So this is another excellent slide. It shows the sex-specific risks and sex and gender differences in risk factors and the clinical features of both men and women with type 2 diabetes. So women with increased risk factors like waist circumference, more BMI, more prior GDMs, PCOS, NAFLDs, all this is going to cause increased chances of developing type 2 diabetes. So she goes into a pre-diabetes level first. IGTs are common in women. Leading on to, along with this, we should consider psychosocial factors too. So as the maternal health of a woman is very, very important. Whether she is undernutritioned or she is overweight, it will predict the development of hypertension, type 2 diabetes and IGT. So she's going to give birth to either big baby or a very small baby. This is mainly because of the intergenerational programming. So what happens, as I've told you, the epigenetic changes take place before the 10th week. We cannot change it. So if the seeds have been already sown, the intrauterine environment is going to be associated with a very adverse metabolic effects in the offspring, promoting an intergenerational cycle of obesity, cardiovascular disease, and NAFLD. So diabetes keeps begetting diabetes. So baby is born, either because of the genetics or the environment, low birth weight or large birth weight, it's going to be an obese female with NCD risk. Going on to the adolescents, the most common endocrine disorder we see is the PCOS, which is considered a complex metabolic disorder. It is an insulin resistance syndrome with all the components which I've shown here. So a young woman with PCOS comes to you, concentrate first on her lifestyle, weight loss, metabolic well-being, and also psychological support should be given to her. Once you start telling her she's going to develop all these complications, she's going into depression. So we need to concentrate on this so that we lower her risk of type 2 diabetes, CV disease, lower risk of GDM, and pharmacological treatment can also be given as per the guidelines. Going to the risk factors for cardiovascular disease in men, as we are in women, as we know the well-established risk factors already, sex-specific risk factors need to be taken in control, like the premature menopause, gestational diabetes, hypertensive disorders, PCOS, and also the under-recognized disorders like psychosocial disorders. All this should be taken into consideration in order to prevent the cardiovascular disease in women. It's not moving. Okay. So since the major cause of death, mainly in females, is not because of uterine cancer, ovarian cancer, or breast cancer. It's mainly because of cardiovascular diseases. So we need to be very prudent to keep CV protection in mind when managing women with diabetes. We should avoid drugs which cause CV harm, prescribe drugs which offer cardioprotection. So going on to pregnancy, the mainstay of pregnancy will be the preconception counseling. Good glycemic control is very, very important in order to prevent complications both in the mother as well as the baby. And also we need to we need to give a good education to her. If she's not planning pregnancy for now, advise contraception. And she also needs to reduce her weight. Going on to complication screening, eye screening should be done, renal screening. As you know, pregnancy aggravates nephropathy and retinopathy. Also, the other complication screening must be done. Vaccinations should be given. A complete renal screening should be done. And we should be very clear on what we educate to her in order to prevent complications during a pregnancy. And safety of drugs, very sorry. I've written metformin, we need long-term safety data. We've already seen from Sir, metformin can be given, glyburide is not advised. Insulins are the most which is what will give good control, is actually insulins are prescribed to most of our patients. Stop statins. If the patient is a hypertensive, stop ACI and ARBs. Consider alternatives like labetalol, clonidine or prazosin can be given. Start folic acid to prevent neural tube defects. So give low-dose aspirin in order to prevent preeclampsia. Because pregnancy, as we know, is an NCD risk. So normal weight, ideal weight woman gets pregnant. During her first pregnancy, she gains weight, fat mass, visceral fat will increase. And after her delivery, if she does not lose weight and she gets pregnant again, she's going to again add more weight to her. This is going to lead to chances of increase in GDM, preeclampsia, and hypercholesterolemia. And after her delivery, she still does not lose her weight. So then there'll be an increased chance of developing metabolic syndrome, cardiovascular disease, and diabetes too. Postpartum care, she may not need the amount of insulin she needed before her delivery. So keep monitoring her blood sugars, ask her to breastfeed immediately, look into postpartum depression, talk about contraception in her immediate postpartum visit, and OGTT, advise OGTT at 6 to 12 weeks to predict whether she will develop diabetes in future or not. Lactation, breastfeeding, I told you, immediate breastfeeding should be done to reduce neonatal hypoglycemia. It also protects from cardiovascular disease, premenopausal breast cancer, ovarian cancer, and also to lose weight in a woman. Going on to the menopause, already we know the established causes like obesity, diabetes, bone and mental issues, urogenital problems, cancers, psychological factors should all be taken into consideration when a menopause woman comes to you for treatment with for diabetes. Stroke, as you know, is 27% greater risk of stroke in women than men has been proved in many studies. Chronic microvascular complications. It increases sensory neuropathy and renal complications due to increase in more in inflammation and oxidative stress in women. More of neuropathic pain and nerve injury in women than in men. Diabetic retinopathy seems to affect both the sexes equally only. And lifestyle, psychosocial factors play a very big role. Lack of health care, social and cultural disparity, discrimination at work, disparity in marriage, restricted medical facilities, depression, low socio-economic conditions. All this at each visit, keep educating her, keep counseling her, make her positive as stress plays a very big role in her control of her diabetes. Bone health, as she progresses, diabetes itself causes a change in the microarchitecture of the bone. So there'll be increased fragility. So recurrent falls which occur in old age will lead to increased risk of fractures. And look into the medications what you have prescribed. Glitazones increase the risk of bone fractures in postmenopausal women. So be very careful about it. And this is a nice paper on gender differences and adverse events reporting associated with anti-diabetic drugs. Women have been found to report more of adverse events with drugs like these thiazolidones, SGLT2. Like in SGLT2, we can see urinary tract and genital infections. In thiazolidones, there is more of edema, fluid retention, and bone fractures, I've already told you. So when we go into the gender-specific care of diabetes mellitus, we need to consider her at every level. Whenever she comes to you, we actually follow like first lifestyle, then pharmacology. It's not like that. At every level a woman comes to you, screen completely. You need to treat a diabetic woman as a whole and not only the diabetes itself. And keep educating her to come again for follow-ups, which is more important. Because lifestyle will be the mainstay, because we found with lifestyle, weight loss alone, the patient has decrease in the mortality as seen. She has become more positive. More weight loss will prevent the development of diabetes. You can actually control her diabetes and reduce the risk of metabolic cardiovascular diseases in her. So in a simple algorithm, if a woman with diabetes comes to you in the reproductive age, she's planning pregnancy, then follow the preconception pathway. Not planning pregnancy, recommend contraception, choose drugs as per suitability, counsel her for risk of unplanned pregnancies. This is very common in all our practices because they come to us 6 to 8 weeks, we have actually lost the time on which we can get control. So please keep educating her about unplanned pregnancies. And if she has planned pregnancy, you redirect her to a preconception pathway. If it's in the post or perimenopausal, screen her for all her complications. So the ideal strategies will be young girls, adolescents with insulin resistance or pre-diabetes, focus on her weight management, lifestyle modification, pharmacotherapy. Young woman with diabetes, assess her reproductive status. She's pregnant or planning pregnancy or contraception, avoid medications that are unsafe in pregnancy, follow the preconception pathway. She's pregnant, give a tight glycemic control, ANC care is needed, diabetes and comorbidities management is needed, delivery and postpartum management is also very crucial. And postmenopausal, avoid medications which cause bone fracture, CVD risk management, do more of a supportive care, avoid medications which increase GTI and UTIs. So my take-home message should be, it is time to recognize and accept these gender-specific differences and practice gender-sensitive strategies to deliver quality care to all women with diabetes through different stages of their life course. Thank you very much for your patient listening.
Thank you, madam. Thank you for the excellent presentation, how you separated between young girls, adolescents, women, elderly women, postmenopausal. How do you differentiate it and told you a lot of things and the side effects. You made it to your point that women are more prone for the disease of diabetes rather than men. Thank you very much. Nice of you.
So actually,
Hopefully this
acarbose,
question- yeah, I'm
sorry. Acarbose, that is alpha glucosidase inhibitors, is again same as insulin. It's a B, class B, like insulin. But I don't know why all are using. I have used in more than 1,000 patients. Yeah. It is as you said, it's locally acting. It is locally acting.
Sir, see, we all are practicing evidence-based medicine. Unfortunately, when it comes to clinical trial, which is a structured, randomized controlled trial of acarbose, the number is very, very small. And no drug authority have really approved it, except very few. For the most few of the organization, US, not Indian government authority have not. DIPSI did not officially approved it. Off-label, if you want to use, people are using it. I'll address upon this. There's a very strong point for discussion. When it comes to pure gestational diabetes, it's basically a postprandial hyperglycemia. Fasting is usually normal. So there's definite role of a drug like alpha glucosidase inhibitor, that only acarbose, voglibose never had been tested at all. So it's only acarbose, but unfortunately in India, we officially will be seems little difficult. I have to be little cautious on this. Yeah. Insulin remains the drug of choice, but that is for sure.
Dose is very high. It says that if you start with metformin. Metformin alone, as Sir said in primordial prevention, what we are using, it has got plenty of uses, but acarbose cannot be started like that. It can be used, what we are doing is we are using along with insulin.
And very important, yeah, one very important, along with insulin, yes, yes. And very important here again, there is no data of combination of the therapy. Even glibenclamide has been approved, metformin approved, but there is no data of combination of glibenclamide and metformin, what Indian doctors are used to practice, that we use combination, and that is why I can't even allow you metformin with acarbose here. That's the problem.
Canadian people or Canadian government is using
Glyburide, we don't have Indian data available. That's why Government of India has not approved it. And this is only Oded Langer from South Africa, who is a pioneer in using it. But most of the data are not in favor of glibenclamide. They still say, even if they have a meta-analysis of glibenclamide versus metformin versus insulin and the combination of insulin plus metformin, all this data doesn't favor glibenclamide. It still remains the third drug.
So the take-home point for GDM is, except insulin, nobody can say other drugs are safe. But there are clinical experiences, and we have been using metformin for a long time, except for what Dr. Sunil had specifically told about the small for gestational age. It will be a long-term data, but what he specifically mentioned, they catch up the growth in the next 2 years. So whether metformin may have a long-term consequence of cardiovascular is also not very clear. If it is a precious pregnancy, definitely never take a chance, always use insulin. It's always the dictum.
So any yes.
Sir will be.
Metformin should not be an alternative to insulin in GDM. And second point, patient does not want insulin, so I initiated metformin. That trend should not be there.
I feel there should be very, very clear message to this very elite audience here. Very clear message, please don't forget this. What are the contraindication for metformin? If you remember this, contraindication is women had bad obstetric history in the past, polyhydramnias, oligohydramnias, IUGR, if you have hypertension, preeclampsia, or any evidence of placental insufficiency, microangiopathy associated, all these are absolute contraindication for metformin. Insulin remains the drug of choice. If you remember this, there will not be any debate of metformin versus insulin.
So any other questions to Bhavadharani madam regarding an untold reality? She made it a reality. We have to target the fetal.
We'll be very happy if many of you take up this, what we are doing. Primordial prevention, we have started and we have succeeded. That we are starting metformin at 8th week if the blood sugar is between 110 and 119. If it is 120, it is a positive case of GDM you have to treat. Whereas between 110 and 119, if you put them on metformin till delivery, we are able to prevent. Please, all of you take up this and give your results also.
check the blood sugar, but within that limit, should I again test it at the 10th week?
Of course, 10th week, please don't wait 10th week. 10th week predicts GDM. So you have to bring down before 10th week. That's what we are saying. 4th week, again repeat at 8th week. Repeat at 8th week, not at 10th week.
Sir, the question is to Sunil sir. Sir, Sunil sir.
Sunil sir,
Sir.
you have a question.
Sir, why is it contraindicated, sir, metformin with microangiopathy in pregnancy? How did we derive this data, or what is the rationale, sir? Any study, or is it common sense, sir?
No, there is a perception because the mitochondria, if you go through the real hardcore basic science studies, it might have its impact through the effect on the mitochondria, and it might precipitate acidosis at a cellular level. And this acidosis might be lactic acidosis, or any precipitation of the early form of the acidosis might have its impact on the outcome. That's what.
So, but we have proved.
Let me finish. And more important is, most of the studies, even if you go through the MIG trial, even if you go through the MITI trial, they have shown there is small for gestational age. When baby is already IUGR, you already have microangiopathy, you already have placental insufficiency, you already have hypertension, you already have preeclampsia, you already have vasculopathy associated with the patient. In such patients, if you give metformin, there is further risk of having the acidosis, which might have its impact. And these babies are already small for gestational age babies. So this might have a bad effect. That's the perception, and that's the data. That might get precipitated.
Okay, sir. But just for discussion's sake, sir. Sir, but metformin has been shown that it increases lactate level, but not lactic acidosis. So this is a myth that we tell, like metformin causes lactic acidosis.
We have the MIG trial, which is like UKPDS in type 2 and DCCT in type 1. MIG trial is like in metformin, and they have shown small for gestational age. MITI trial in type 2 diabetes, they also shown for SGA. So when baby is already SGA, IUGR, why should we give?
Okay, sir.
That will precipitate. That's the thing.
Any other questions?
Any other questions? Otherwise, we'll wind up. Yes, one more question is coming.
Sir, again, Dr. Sabdarji Patacharya from Delhi, he has studied regarding metformin, and he has put on metformin, followed the babies up to 11 years, and he says nothing, like what we read in MIG trial.
I have a question, sir.
Now, if you go through this trial, you have trial from Europe as well as from US, and preconception, pre-gestational type 2 diabetes now. Both of them are showing non-inferiority.
We have the last question for the
I have a
session,
question, sir. Regarding the use of metformin, what is the maximum dose which we can give a pregnant woman?
We do not give above 2,000, so not more than 2,000, but we start with 500 milligram, then built up to 1,000. Maximum is 1.5 to 2 gram per day.
How fast will we escalate this?
I feel
every 1 week, 2 weeks?
It may be 1
Weekly.
to 2. Maybe weekly is good enough, yeah.
Again, remember, this metformin cannot give the total control what you expect. In case we are not getting, definitely you have to go to insulin. And better, if you can, start with insulin, add metformin, if the dose is very high.
50%, I'm coming for the photograph, let me answer. 50% of the women, 50% of the women may not need, will need insulin add-on to metformin.
So, yes, we'll we had a extensive discussion of starting from fetus, targeting the fetus for prevention of diabetes. Next was medical nutrition therapy and non-insulin therapies in GDM. The final topic was women, how they are different, manifesting as the DM and complications. And metformin was the hero today. Whether hero or not, we don't know. As to answer, madam, in GDM, always don't go beyond 1 gram. Always better below 1 gram. If it is not there, always go for insulin. That is we'll thank you for the opportunity. We'll wind up the session.